Okay, thanks everybody. We'll get going. You're all very welcome to the fourth Reach Network event of the year. Um, a welcome from me. I'm Robert Scully. Just a few brief comments before we get going. For those of you who are new to the network, essentially what we're trying to do is address a gap in CPD. Colleagues in the cities often are involved in larger health ecosystems, and that's different to regional or rural health ecosystems, particularly Model 2, 3 hospitals and rural general practice. So what this network hopes to focus on is enhanced clinical generalism. We need to celebrate generalism and interconnectedness across our network, across our services and between colleagues. So we aim to address this through these meetings, which will be largely clinically focused, always generalist focused, but we'll also discuss healthcare systems, connected health, and relevant policy. And this talk today is the first really of our health services, healthcare systems discussions, which we'll talk about in a moment. Some housekeeping. This is a virtual meeting. It's being recorded. We are having an in-person meeting later in the year, which we have funding for. And there's an expression of interest form in the chat, and all members will receive that form via email also. Previous meetings, I think, are maybe up on our YouTube channel. Is that right, Honor? I think so. If they're not there, they'll be there soon. The presentations are about 40 minutes. There's an opportunity for questions. I'll moderate the chat function, and I'll invite you at the end, if you do put a question in, to raise your hand and turn your camera off if you're up for that. Please keep your microphones muted. There's CPD available. The hospital buddy code is there, hashtag 9025, and ICGP CPD is pending, and we will circulate that accordingly. We're always looking for new topics, anything that champions clinical generalism. And if you do have a topic that you'd like us to consider, please send it to the Reach Network at universityofgalway.ie. And as always, we'd appreciate your feedback. So please fill in the feedback form. The network is growing. We now have 500 members across disciplines. A really nice contribution from students, general practice, hospital-based consultants, and our health and social care colleagues. And just important to say that all the information is obviously intended to be as accurate as it can when the talk is given, but this presentation does not replace clinical guidelines and should not be used as such. Before we get on to today's speaker, our next meeting is on the 19th of March. Delighted that our colleague, Professor Derek O'Keefe, a consultant physician and professor of medical device technology here at the University of Galway, will give this talk. As many of you will know, Derek has a wide portfolio of interests and activities, and is involved and leads the Healthy Island project. And his talk will be Digital Transformation for Rural Medicine, Engineering the End of Distance Decay. So really looking forward to that, and really grateful to Derek for his time. So please register for that when you get the reminder. So without further ado, we will move on to today's speaker, my friend and colleague, Professor Michelle Canavan, who many of you will know is a geriatrician, celebrates clinical generalism and involved in ICPOP and integrated care in our region. A catchy title today with a snazzy poster: Integrated Care for Older People in Rural Settings, the Good, the Bad and the Ugly. So I'll stop sharing and hand over to you, Michelle, and thank you.
Thanks, Robert. Thanks for the introduction and thanks for the invitation. I'm just going to get my slides up here. The title was just to draw you in, and hopefully it'll make sense as I go through. So just to say, sorry, I just want to make sure I'm on slideshow here. Can you? Oh, there we go.
Yeah, I don't think you're on slideshow yet. There you go, Michelle. That's perfect.
No, yeah, perfect. Okay. Excuse me. So thanks very much. As Robert said, I'm Michelle Canavan and a geriatrician, and I love talking about integrated care for older people. As many of you on the call will probably know, what I want to do is focus a little bit on the ecosystem we have now for integrated care for older people, and the kind of general principles of integrated care, because I think they're really relevant to the way our healthcare landscape is changing, and the particular implications for rural care that has. So the good, it's mostly good, and I didn't want to get too negative with doing the bad and the ugly, but there is always room for improvement, and I'll touch on a few of the things there that would really improve things. I'm going to talk about the principles, talk about age-friendly health systems. I think as our population ages, that's going to be a really important focus. A little bit about the rural context for older people and have these services benefit for the older person. I hope I will convince you that they have. But I do think we'll also touch on how we deliver it, how we're going to ensure that it's equitable and sustainable, and the whole pieces around population and resource planning. So a few disclosures, unashamedly West Northwest focus. So a lot of my examples will be based in our region, mostly probably in my own Galway area, in terms of the patient care pieces. The perspectives I'm given on integrated care in general are just my own lived experience and personal reflections over the last couple of years. And just like, integrated care by definition is a team sport, and I'm really representing a really committed team of individuals in this region, who have really made a difference to older persons' care. And I suppose just, when we reflect on where we work, this picture here of the sunset is the lake in Loughrea, which I can look out the window to at the end of my clinic, which is fabulous. And we have such a wide and varied landscape, which does give certain challenges. The other picture there is the health centre in Inishbofin. Just to kind of keep those places in mind where you're thinking about how we deliver this healthcare and how we make sure everyone gets it. So the good, first up, everything about the good is usually people related. And there's just a quick picture of our team in ICPOP Galway East, and I'll also refer to ICPOP Galway West. And there's similar teams right throughout the region and the country who are doing this. And it is about the people, and how we deliver this care. And people being passionate about care of the older person is half the battle. The systems and the constraints within which we work. But if we always try and improve things for the individual in front of us, that's always a good start. So just to talk a little bit about like setting the scene really, like we know Ireland has the fastest growing population in the EU, in terms of older people. And you can see that particularly the age groups from the 80s to 84s and 85s and over are essentially going to quadruple by 2057. We need to be planning for that now. We need to be ensuring that we have the structures in place for that. And the integrated care program for older people, initially was designed around that whole piece. It was so ICPOP, you'll hear, is the acronym, so Integrated Care for Older Persons Program. Was developed, driven by PJ Harness, Siobhan Kennelly in the early days, and it was based around these 9 pillars of integrated care. And this is a slide from the International Federation of Integrated Care website. And I suppose I just want to draw attention to the values that we have there around that idea of having a shared value and a vision, looking at the population health and the local context. And I think this is really important for us as we design services and sustain services in rural locations in particular, looking at people as partners, the idea of resilient communities and new alliances, and the community healthcare partnership, which is really key. Workforce capability and capacity. We know we have a lot of shortages in rural healthcare delivery in terms of staff, and we need to provide new solutions and innovative solutions around that. The digital solutions piece is key, and then that whole idea of how we measure it. What is the results and what are the impact of these programs, and how do we look at the governance that underpin them? And obviously, this is all lined up with Launch a Care program, which is looking at the right care, right place, and right time. And these were just the kind of various documents that came through to kind of guide us in how we set up these integrated care services. And this 10-step framework, I have to say, has stood the test of time. And I go back to it time and time again, because it lines up all the things we really need to do to ensure that we're able to stand over our services, that it's aligned to our local older person's needs, and that we're planning for the future. And this piece in the middle, the supports to live well, I'll touch on it throughout the presentation, but I think that's one area where we're probably not spending enough time at the prevention piece, looking at our population aging down the line. The enablers, you will hear me talking about as well, because that's another. Oh, okay. Dr. Qureshi, there, you might mute if you can. Thank you. When you're starting up any sort of program, it's always about showing value. And I think this was a case study that they undertook with the initial 4 pilot sites for the integrated care program. Usually when we want to get healthcare, the HSE kind of attention of something being good, we have to look at showing a value in length of stay in hospital. So this is all about bed days saved, readmissions within 28 days, reducing the amount of admissions for 85 years. And we know that older people in hospital don't do well, and there needs to be an alternative option for that. But I suppose as we go through the presentation, you'll see how that mindset is probably changing, and we need to look at the quality of outcomes that we measure and what actually matters to older people in terms of what's measured. So while our HSE management colleagues and ourselves might be obsessed with how many days we can shave off a stay in the hospital or how many patients we can see in a clinic, does that matter to the individual in front of us? But on the flip side of that, which was very useful when they're starting up this program, we did show a lot of savings by simple interventions of joined up, integrated multidisciplinary care for older people, which most of us who work in this area know that it works. But how we deliver it on scale and how we ensure that every person who is entitled to it gets it is a different thing. So just to remind people, the enhanced care model was kind of there was a big investment in this, about 2.4 million billion, sorry, in 2020 and 2021. And the aim of this program was to establish the 96 community healthcare networks. There was 32 community specialist teams for older persons and chronic disease programs. So the chronic disease program encompassed diabetes care, cardiac and respiratory care, with the idea being that people could access a specialist ambulatory care in the community without having to go to the hospital for it, which obviously suits older people. And I suppose just to kind of give you an idea of what was funded, sorry, go back to that one. We had consultant funds funded, we had registrars, we had the full multidisciplinary team. And that skill level and expertise, particularly senior HSCPs, having physio OT assistants, having proper administration, and a grade A team coordinator was really key to the development of these programs. It wasn't just setting up a team, it was setting up a community of practice, it was setting up the links that are needed to actually deliver this type of care. And the highlighted ones there, just to remind us, like not everywhere in the country has consultant geriatrician in place. Not all the posts have been filled. We've had a deficit of social workers, for example, on these teams, which, you know, was one of the key posts. And then the idea of these 0.5 positions can be tricky to fill and to maintain and to keep people. And, you know, when we're thinking about our service planning and our workforce planning, we need to think about how we, you know, get these jobs out there and get people interested, because particularly we have deficits in HSCP posts, particularly in rural areas, and that idea of having people maybe, you know, that are from those areas in jobs where they can advance their careers and advance professionally is really important. So basically, ICPOP community specialist teams are the idea is that we're an interface between the acute and community care for older adults. So we work in partnership with older people to coordinate and provide that enhanced health and social care services. And we want to avoid unnecessary hospital admission where we can. And this doesn't mean older people don't need hospital services. And when they do go into hospital, they need to have age-friendly, age-attuned services, similar to how pediatrics need pediatric attuned services. We haven't been so good at making sure our hospital environments and our community settings are age-friendly and age-attuned, and particularly dementia-friendly as the number of people with dementia increases. The initial setup of these teams, with the idea was everyone's going to have this lovely all singing, all dancing hub where we could actually carry out these things. That didn't necessarily happen. We had to kind of make the best of what the resource for the areas that we were in. So a lot of us started off, and it happened to coincide with COVID, where we ended up doing a lot of domiciliary visits because we had no clinic space. But that in itself taught us a lesson that, you know, older people really value the opportunity of being assessed at home, and anyone who works in rural medicine or in general practice knows the value of seeing someone in their own setting. And they're much more relaxed. You get more out of it. You observe how they live, and the social determinants of health, which we all know are really important. And I suppose, you know, when you're on the move and you've no fixed abode, you have to be resourceful. And we have tried to use digital solutions to try and enhance care where we can, and to use the resources to the best possible. And I'll come back to that in later on. And it's just to say, we hear a lot about ICPOP as, you know, the kind of integrated care. Like ICPOP on its own is not integrated care. It's just part of a continuum of older person services. And if you look at this pathway here, older people can line up for you know, so they can hit this pathway at any point. So living well at home, we want to think about falls prevention classes. We want to strengthen people. We want to enable them to live in their own home. We want to provide the home supports if they need it. If they go into hospital, they need to be assessed by a specialist geriatric team, and that's where our frailty at the front door teams come in, and they were also funded through the CCT program. They need specialist gerontological care in the hospital, and actually, you know, all clinicians in the hospital need to be geriatrically attuned and trained, because it's, you know, a geriatric can't take everyone, but everyone. We look at the average age in the hospital, is 70 plus a lot of the time when we look at our daily takes. So just to kind of make that point that sometimes, we hear the minister talking about ICPOP and how it's been wonderful, but it's not the be all and end all. We have to look at all the other parts of the puzzle as well. So just a few little practical bits. So we've been kind of refining this criteria as we've come on. This is kind of our latest kind of version of it that we're hoping to come out with a guidance document. But so it's kind of a high level referral criteria. Each local area probably has their own nuances based on the services that were there beforehand and maybe, availability of consultant support, for example. So the program was set up originally for over 75s. We use a clinical frailty scale, and if you have a clinical frailty scale of between 4 and 6, you generally need some assistance with your activities of daily living. You're becoming a bit more frail, and these are the group we want to intervene on and maintain their independence as much as we can. And we're basically focusing on frailty, falls, and change in cognition. And really, the thing that sparks a referral for us should be a decline in cognitive or functional baseline that needs specialist intervention. And we've also kind of this idea of like there's lots of people who've complex health and social care needs who shouldn't, wouldn't, or couldn't come into hospital, and we have a lot of patients that don't want to go near a hospital or a doctor. And the service has been quite good for engaging with those patients, getting in as much support as you can. You can't win all these ones, but there is an element of that. And then we also, so it's not that we're supposed, for over 65s in general, but the service has limits in terms of resources, and we do obviously people can be much frailer. There's lots of social determinants of health. There's immigration. There's all sorts of things that can impact on people, and they may have the exact same needs at 65 as someone in their late 80s. And then that whole piece of it being a specialist service, so specialist multidisciplinary intervention needed to help maintain their independence. And then, we're trying to be sensible about the service. So if patients have acute medical needs requiring acute medical care, that's it. They need to go to hospital, and GPs are very good at figuring that out. Where the services could be met within primary care or another service, and where there are safeguarding vulnerable adult concerns, we get a lot of these referrals, and obviously we do see that from the medical multidisciplinary support perspective, but some of those need other services. And if you just look at the top one here, you can see our referral sources for Hub, and this is just the Galway, Mayo, and Roscommon kind of IHAs. You can see that our referrals largely come from GPs. Increasingly, we're getting more from acute hospital admissions. So we see people that get a quick egress from hospital. We follow them up with a quick visit to make sure everything is okay. We link them back in with us. And that has been working very well. The other thing that's working really well is the Frailty at the Front Door service will pick up a patient that come into ED, hopefully turn them around at the front door with a quick ICPOP follow-up, or even if they end up coming back home in a few weeks later, we have those links made. And it's this linkage and signposting and trying to minimize the amount of harm that can come to a person in hospital, because we know that that is a real thing. So we do prioritize patients who've had an acute admission to the hospital, because we know that can result in, like, if you look at all over 90s who present to hospital, 65% of them have a functional decline by the time they come out. They're incontinent, their mobility is off, and we want to try and minimize that where we can. Referrals come to us via health links, and that's the clinical frailty scare I spoke to about. So we're kind of trying to concentrate on those ones. We do look at people who are severely frail, completely dependent. Oftentimes there's maybe end of life care. There's transitioning into long-term care, which is another thing we try and do in the community without them having to go to hospital to transition in there. From a GP housekeeping perspective, up-to-date list of medications, which usually comes with health links. Social context, background, a few lines from a GP who knows them well is absolutely golden in helping us to triage them. And then the private system people who've been seeing the private system, we may not see things. So sending those, so we don't reinvent the wheel, do loads more investigations that we don't need to do, and we try to minimize investigations. And then the double referral particularly from the dementia perspective of ourselves and psychiatry later life. But that's something we've worked very well with our psychiatry colleagues, where we would triage between ourselves, depending on what's most appropriate. So what do they get? They get a comprehensive geriatric assessment, and you'll hear me talking about CGA for short, but it's just a full holistic assessment focused on their functional capacity. We look at falls, cognition, mood, sleep, continence, polypharmacy, what are their social supports, and we do start talking about goals of care and advanced care preferences. And when we talk about goals of care, we talk about what matters to the person. And you'll hear me talking about the 4Ms and the age-friendly health system, which is coming in now, which is really important, because the first thing in that is what matters to the patient. So I may be 85 and completely bedbound, and my goal of care might be I want to be able to sit out in the chair and see my grandkids coming down the road, or people's goals can be very individual to them and not necessarily what we might think their goals are. And I think the intervention is really important. Sometimes we do a lot of assessments without a lot of intervention. That may be one of the criticisms of these services. I think we have to follow on with the intervention piece, the linkage with the relevant services in the community, and that teamwork of keeping the patients going in the community is really important. We do have our frequent flyers, and we usually try and link those in with our AMPs or consultants, because and the families then know to give us a ring if things are going off, and that can often stave off a hospital admission if we can intervene, change some medications, do the basics. So that idea of having those frequent flyers is important. And I suppose we try and adopt a patient-focused approach. So by necessity and maybe not by design, we didn't have ambulatory hubs. So we kind of beg, borrow, steal spaces wherever we can. The St. Francis Health Centre in the town here in Galway City. Some of the West team work out of there. And we were out to people's houses. And we used the CRF in the university for a while. And we now have a little a hub in Tuam where we see patients. I do a clinic out in Loughrea Primary Care Centre. So again, it's trying to minimise the journey for the patients so they can come, in as easy as possible. Like the palaver of someone coming into the main university hospital and trying to park, even myself getting parked as someone who works here, is a nightmare. Not to mind if I'm 95 and I'm coming in for an appointment, and we don't want people sitting for hours waiting to be seen. So that kind of stuff is really important for older persons, and we've had great feedback from both the domiciliary visits and the local clinics. So just to give us a sense of where we are with these, just in terms of our numbers, and I'm just conscious of our colleagues in Donegal and Sligo, and as well as Galway, Mayo, Roscommon, and you can see here where we have the population levels, and I suppose it's just to kind of look at the numbers that we have that are over 65. So we have one of the highest proportions in the country of older adults over 65. And as I said earlier, the over are going to double or treble in the next 10, 20 years. And I think the over 65s in general are going to at least double by 2057. So, there's a kind of a sense of, we have all these integrated care teams and it's great now, but they actually need to be stood up and expanded if we're going to deal with the amount of older people that are going to need the services. And each place has kind of developed their own models. We have a kind of an idea where we have clinics in various towns. We have Loughrea, Tuam, we have Carraroe, Moycullen. And my colleagues on the West team, Dr. Maria Costello and Rob Murphy, have been doing visits out to the Aran Islands, out to Inishbofin, to try and reach all those patients. Similarly, in Mayo, they're out in Belmullet. And in Roscommon, we have clinics in Boyle and Castlerea, as well as in Roscommon town. So the idea, again, just trying to reach all the patients. I'm not as familiar with Sligo and Donegal, but certainly they have the same idea in terms of how they deal with their referrals. And that idea of the hub and spoke model is really important. And you can see here they have hubs in Leitrim and in South Donegal for the Sligo team. And just to say, as you go up into Donegal, and Claire McAleer is here, she's always beating this drum, but, they've struggled to get consultant positions in their ICPOP team. They have a really wide geography. There's one tertiary referral hospital there, Model 3 Hospital in Letterkenny. So, again, it's trying to make sure that the people, the older people in Donegal who are, maybe a bit more rurally isolated, have access to these services, and that is a work in progress. Just to show, we're measured quite tightly for these services, and more so than a lot of the services in the hospital, I might add. We've really been under scrutiny, and fair enough, there's been a lot of investment into this. But I suppose my point here is around kind of what we're actually measuring. And I suppose number one, are we seeing the right people? I think if you look at the patients that have the clinical frailty score, where we can intervene and probably improve things, we are probably seeing the right patients. We're kind of hitting on the right conditions. And I suppose if we just look at CGAs completed in 2025 for our own IHA, so Galway, West Galway, East Galway, Roscommon and Mayo, over nearly 1,400 will comprehensive geriatric assessments and over 2,000 referrals in general. Some obviously referrals aren't appropriate, or they'll be gone somewhere else. So, you can just see by that how the service demand is there, and it's going to increase. And we need to bear that in mind as we're planning for these services. And I suppose just to kind of bring in, so Emer Ahern, who's the national, the NCAG lead for geriatrics, has been really strong in developing this age-friendly health system, and it's coming at a really opportune time where we're developing pathways and networks of care within the existing or within the new HSE structures. And it's really timely that we look at end-to-end pathways for older persons. And this age-friendly health system is, designed on four basic principles and that are integral to older person's care. So what matters to the patient, what medications they're on, what's their mobility, their ability to function, and then do they have like cognitive impairment, mood disorders, all that sort of stuff. So you just have a framework to build your health services on, and they're setting out a really ambitious vision that by 2030 Ireland will become the first country with an age-friendly health system, and that's going to take a lot of work and buy-in. And I think that can be done within the integrated care programs. We all need to look at all our services and see how we can assess our own services. Are we delivering our services in line with the four M's? Is what we're doing mattering to patients? And so this is the older person service model. Like you've seen that document before, but I suppose what the idea will be now into 25, 26 will be that it's based. We have these pathways, where we have our specialist hubs, we have the hospital care, and we hope that they spend the minimum amount of time in here. That when they go in there, it's attuned for them appropriately and they're egressed properly. But the majority of time we want people in here, and we want people to be living well at home. We want to improve the preventative services that they might need in order to do so. So getting on to the rural context, anyone probably that's interested in this network appreciates that the rural context is different. And this is Maria Morney Naughton and our public health colleague in Inishbofin there last summer, where they did a visit. And this was in conjunction with the Healthy Islands project with Derek O'Keefe, which you'll hear about next week. But even getting there is a challenge. We're on the ferry. And we're trying to use the resource to the best potential. So we've planned ahead. Maria's going out there saying that, is there anyone on the island you want us to see? We kind of go out there, do the comprehensive geriatric assessments. And then once we've seen them, we have ability to maybe follow them virtually to save them coming over from the island. So there's loads of little tweaks that we're trying to adapt our services to meet the needs of the patients. And I suppose just to kind of, you can get a house like this in an urban setting, don't get me wrong. But when this is the setup of somebody out literally in the middle of nowhere in East Galway, and the insulin pens are in the cup here beside the golden frisky or whatever else is required for the lambs, you can see how the social determinants of health can really impact on somebody's ability. And you can also see what's important to them. They could have quite happily lived in this setting for a long time, and you're coming in here telling them they should do this and that. So, we have to tailor our services to the needs of the population is the bottom line there. We know that rurality affects people's access to healthcare. And you can see, from if we look at a national perspective, we have one of the highest levels of deprivation in the country. Apart from Galway City and the surrounds here, there's very little of the blue and purple. There's no Shrewsbury Road and Monopoly. My kids are into that at the minute. But mostly we're at average level of deprivation or below, particularly as you go further west, northwest, and up into the north. And it's not that but we need to plan accordingly for this, and we need to be thinking that if we're designing healthcare services, we're looking at graduate students coming out that we want to work in these areas. We have to resource them appropriately and make it an attractive place to work, but also to have the services that are catered to the needs of the population, because what works in Galway City or Dublin City does not necessarily work in rural areas. We all know the headlines around these. Community hospital can't staff. A third of the doctors are leaving, and we have a GP crisis in terms of recruitment for rural GP practices. And I suppose, we also have healthcare professionals, care professional shortages as well, and which does impact the overall primary care team. We have long distance travel times, and this is just a quote that Maria had from one of her patients, family members. The idea of boarding up an 80-year-old onto Cleggan Pier, getting out the other end, driving into the hospital, not able to manage. And then if they miss the boat that night, or if the weather is bad, they're stuck in Galway trying to get accommodation. And that idea that you don't count the miles, it's the hours involved, because these people are used to traveling. They know they have to. But I suppose if there's ways we can address their needs differently, we should. And just a note on dementia. So, there's some studies of dementia in rural settings, and we know that people with dementia And there are, positively, there's often a greater community support and people are very neighbourly and they look after people. But that engagement with people is maybe thinning out as well. And what we used to have before in terms of the Mehel and the neighbourhood surrounding may not be as obvious as people have emigrated, families are no longer there. So we need to think about how that works. And people with dementia, the tools virtually don't always help to kind of us to have a full assessment with these. So and then the idea of staffing, and if we have rural staff on the ground, even in home care services, that importance of educating people around supporting people with dementia is really important, particularly in rural locations. There's been a lot of research in that area. Lastly, we talk about equity of services, and I think, nationally, and I keep beating this drum because it's interesting. I was at a rehab meeting in Dublin not so long ago. And we're pointing out this study where we have 14.3 beds for 100,000 of the population. On the East Coast, it's at least over 20, if not 30. And you can see the huge disparity. We just draw a line down the middle of that chart. And yet we're under the cosh for having too many people on trolleys when we have no egress or rehab options. So, we really need to think of that capacity issue that we have. We think about it every day because we're witnessing it. But I think there's a kind of an issue like we're not doing enough, but we need to be able to be able to give these services because we know what they need. And just also like, so the level of complexity and morbidity is the other thing to think about, particularly if you look at our HSE West Northwest, like a very high rate of falls, ED attendances and fractures in the populations of 70 over and older. And, we need to look at why that is and what services we can put in place and obviously enhance what we have to do that. But it's much higher in our region and in the Midwest here than it would be on the East Coast. So just a quick note on the virtual clinic, and this was Maria having done the visits in Inishbofin using the Healthy Islands project to kind of link back in with the patients. They come down to the health centre, they link in with the consultant, and you can see the value of that. And people are getting very savvy with sometimes they maybe need a little bit of setup, but once you're on screen with them, you can often initiate a good conversation. And it's that idea of having the eyeball test for us as clinicians, particularly geriatricians, you really get a sense of the person when you can actually see them. It's very different to just talking on the phone. Mobile diagnostics, and I'm sure Derek will allude to this in his talk next week, has really improved our ability to. So, one of the biggest things we see are falls. So, our ability to do heart rate monitoring, ensure they're not bradycardic, to do 24-hour blood pressure monitors, grip strength, check for sarcopenia, ECGs, and all the little technologies that can enhance care are really pivotal to functioning integrated care services, and we need a lot more of that to be available. So, has the program made a difference? I suppose I'm going to hopefully convince you that it has. So we can get our own local professional, patient feedback. And in general, it's good. More than every service, there's always a few things where you can improve. But the general sense is that people get enough time to go through all their issues. People feel supported. People feel there's a point of contact where they can go, and they like the idea of the holistic approach. And I suppose from a healthcare perspective, a healthcare services perspective, it's just being that interface, developing the expertise within teams. And I've seen this over the last 5 years as our teams have developed, talking to one of our nurses or physiotherapies on the team, like they know where everything is, they know who to go to, they know how to link in for home supports. Like linking all that up has been so important. And it's often an unseen benefit of these integrated care team models. Links with other organizations. So we're constantly on the phone to Alone, age-friendly homes, getting the dementia advisor involved. That whole idea of community partnership of care for older person services is really important. And then, so there has been an effort to kind of capture this. I talked about how, we don't hear from older people. So this was a really nice piece of research run by the National Clinical Advisor Group around the lived experience of older persons, and you can see a quote there. I never knew that little bit of heaven was so close to my door. I felt isolated. Now I actively go out. My experience has renewed my faith in the Irish health system. And some of this may not be, revolutionizing. I often say to people, I'm not going to make you a marathon runner, but I might be able to make you walk up the road, so, setting those goals and people feeling listened to and heard. And I think, the small things are often the most important and they do add up. And some of these responses I think kind of tell a lot. carer feels that their dad, oopsie, was comfortable and able to keep his dignity. Assessments and treatments in my own home are very meaningful. And there's been a bit of pushback for us as teams around the domiciliary aspect of our care. My answer to that is, well, give us places to see them, but also, there is a value in that domiciliary care approach. And it's a lot easier for families sometimes to manage, depending on the situation, particularly in isolated rural regions. And the idea that everyone takes time to listen. Um, and there is evidence for comprehensive geriatric assessment. So this is a study that was done in older persons admitted to hospital. So these were people who had a comprehensive geriatric assessment in the hospital versus a general medical admission. And this is one of the seminal papers that we come back to time and time again. So you need to treat 17 patients for one person to be alive. And we look at like statins, for example, in prevention of stroke, you need to treat 50 people for one person to be alive. So these interventions are, they're complex, but they're relatively simple in terms of intervention. And to think that you could have somebody more likely to be alive and in their own home, less likely to experience deterioration or move into a nursing home, like these are the things we know are really important to older people. And then you might say, well, does that work in the community? So the evidence probably isn't as strong as that one in this follow-up one, which was 2022, where they looked at comprehensive geriatric assessment in community dwelling frail older people. Again, the quality of the studies was quite variable. But I suppose the big thing that came out of there that they were at a lower risk of being admitted to hospital in people who received a comprehensive geriatric assessment. And for this, when I worked out the numbers needed to treat with a CGA in the community to prevent one planned admission, it's 10. So 10 CGAs, one unplanned admission. We have over 1,300 patients on trolleys in UHG in January 26, and I can tell you a sizable percentage of those are over 75. So that, when you look at that from a logical perspective, you kind of say, why are we not doing more of this, and why are they not concentrating more on it? Sorry. And I suppose we really do need to focus our minds on this, because if you look at functional ability, and this is a study from Tilda where they look at the number of people with functional impairments is going to increase by 5-fold by 2040, and that's reflecting both deficits in physical and cognitive health. And we know that patients who go through the hospital system get a real decline in their function. And so we need to start studying these services and see where we can improve things. And this was a really nice piece of research done by Rose Galvin and her group, where they did a prospective cohort study of a model of integrated care. So this is exactly what we're talking about: a community specialist team for older persons, 303 patients who went through it, and they looked at their incidence of 30 and 180-day functional decline. In the cohort there is going to be functional decline, but the fact that the majority maintained functional independence up to 6 months is actually huge when you think of the trolley numbers and all that, and the reduction in emergency department presentations, and the fact that they reported their health-related quality of life was significantly improved. And we know that frailty is a significant predictor of adverse outcomes. So now that I've convinced you that it's all good, I'm going to just talk a little bit about, and it's not that anything is bad or ugly, but it's just, there are pieces where we could do better. And I think this whole lack of planning on your part does not constitute an emergency on mine. I feel like we're constantly firefighting rather than planning for what we're going to need. And it's kind of that, we did a huge investment in integrated care there a few years ago, and everyone's sitting back going, oh, it's brilliant, sure, everything is integrated now. Not so much, and we do need to plan forward. I think I've a double on this slide, but just to kind of that whole idea about the 4Ms and how we frame our services. And just to kind of think of, so we talked about the older people living well, and that's a success at every lens. If you think about it, we have a really agile, well, older population in Ireland. But as you get older people and people are living longer, you do have this health span, lifespan gap. So while they could be in good health, sometimes the gap where their health is not so good is actually longer, and that has more implications for hospital or for healthcare systems and for how we treat them. And I suppose just the whole idea of where people want to be. And I think older people in general, just by virtue of the way they may decline or get a neurodegenerative condition, it disproportionately affects their ability to choose where they want to live. We haven't done enough in Ireland maybe to think about where people can, there's basically, you manage at home with supports if you're lucky enough to get supports. And if not, you go into a nursing home. And we need to think about the in-between here. And I think the unseen pieces and the reduced autonomy in those choices really can disproportionately affect older adults in rural areas. And there's plenty of I know Mayo Social and Jerry Crowley did a little bit this in the Riddy conference where we heard about the idea of supportive villages for older people from the area, being able to transition from home into assisted living, maybe into long-term care. And we need more of those kind of projects around the country. So yeah, sorry for people said this already, but I think the other thing here is, this was a paper they looked at kind of the implications, the achievements. So we've improved quality of life, we have increased life expectancy, we need to be more, and we've people are living longer from their heart attacks, their strokes, their cancers, but yet we have these social inequalities, and some of this the chronic diseases and the multimorbidity and the complexity of managing that can put a lot of strain on the healthcare system. And I think, we really need to look at healthcare staff working in these communities that are trained to manage multimorbidity. Robert mentioned the importance of generalism there, and I would wholeheartedly agree with that. And that's something we will come back to later. Am I doing time-wise? Okay. Just this one, you don't need to look at it in detail, but it just struck me as I was preparing for this talk. This was a pathway that we came up with in 2020 when we were getting all the funding for this integrated care service. And everyone in the room identified the key enablers, which is ICT, shared records, rapid access to diagnostics from hubs, and being able to screen for frailty, access to home supports, and access to rehab. Have we ticked all those boxes? I'm not so sure. It is a work in progress, but we really need to up the ante in terms of being able to deliver this rehab beds and being able to see, up from as the patient transitions from one pathway to another, being able to see that shared care record for whatever healthcare professional is involved is really important. And I think, that there is this, I'm doing the kind of devil's advocate here now, but, people say, Papa, oh, sure, look at now you have more people, more services, and they're not linked up at all. And this idea is kind of a perverse thing where we get more siloing, even though we're talking about integration. And so we need to think about that, and the linkages are really important. From the HSE perspective, there's a very keen eye kept on us in terms of measurement and performance. There's a lack of patient-reported outcomes and important outcomes to patients. And there's this idea of pitting people against each other in terms of, you're the worst performing place in the region. And this gets trotted out by politicians and by ministers. And it's, it really degrades the work that's been done on the ground, I think, by people. And it also doesn't speak at all to the level of resourcing that was there beforehand. So not to be very anti-East Coast, but there was maybe a lot of established services for older people there, day hospitals, lots of rehab facilities. And then they're comparing that to what we have here in the West, which, was already under funded. The metrics really important to think about. Is length of stay in trolley important in a hospital? Absolutely. But is that what's most important to the person? Why don't we look at time spent at home as a marker of good healthcare? And there's always going to be risks with these things. The amount of people we have where they're like, yeah, I don't care what you're saying, I'm going to do what I'm doing here, and that's fine, and they need to be supported to do that. Two emojis to sum up my lived experience of integrated care for the older persons, cycling between the small wins and getting something, and then complete frustration and confusion, and a few other emojis and eye rolling and expletives. But at the same time, there has been this sense that, I took this from Sarah Barry, who's an analyst in Royal College of Surgeons, and this idea that there's magic integration cream, and just by calling it integration, we're going to integrate everything that we need to. But I think, there's a few things here that we really need to focus on, ICT and information sharing, and then the workforce planning and the skill set of that workforce. Sorry. Service users, they know what's going on. Like, I'm seeing a 90-year-old guy in clinic, and he's saying, how do you mean you can't see all those things I had done in Galway? I thought with computers and technology, that would all be joined up. Like, it is the elephant in the room. It is not that complicated if you look at what can be done with AI and with all the pieces, but we just don't seem to be able to kind of get that together. There is an improvement in it for sure, but I don't think it's happening fast enough. We basically need shared, secure access to patient information for the safe care of patients. And this is a risk to all healthcare professionals involved. If you don't know what someone else has done, it's really important. And we need to invest in the IT infrastructure and staff to actually implement that. And this was just a kind of an idea of sometimes it's just me and my laptop. I've managed to get access to Portiuncula, to myself, to the community, whatever we can get. But not everyone has that. So the ability to visualize what's been happening, and sometimes, you're literally just dancing in the dark, and it's important as a clinician from a risk perspective, that I'm aware of what the GP has done, GP is aware of what we're doing. the relationships and people are key to the success here. And, there's another picture of our team where we had a joint thing with the Freight to the Front Door team, with integrated care, with hospital professionals, with public health nurses. Just, the transitions of care. We know that these relationships are really important and we have to empower them to do this. Like, trust is really important to build in these services, and just listening to people, because what I might think is the public health nurse is not doing this and she's done absolutely everything to facilitate somebody being at home. So just listening to that other point of view is really important. And we all know that, but I suppose it's just, you can't emphasize that enough, really. And our people are our most important asset. And we need to be able to train them, to deal with multi-morbidity and complexity. And we need to attract and retain these skilled healthcare professionals, particularly in our region. We've mentioned all the things about the older persons population expanding, but we need the professionals to actually treat them. And then I suppose that whole idea of, if you look at delivering sláinte care and integrated care, and the kind of deficits that we see in Model 3 hospitals, the deficits that we see in GP, there's been a kind of maybe focus on the Model 4 hospitals. Everything is specialised. These are highly sought after jobs. They're easy to recruit and retain. And then in the Model 3s and in maybe rural GP practice, there is a bit of a difficulty in recruiting and retaining this staff. And, expectations are changing for health care in general. And with the increasing chronic disease and multimorbidity. And I think it just, prompts us to kind of think about how and where we're delivering this healthcare, and where we're training our doctors. So just as a quick thing, we actually gave this to Department of Health because we're trying to make the point about the importance of generalism with our new rural graduate entry medical program here in Galway. And that idea of the patient journey in a Model 4 hospital. And I see this, unfortunately, with the best will in the world. Someone comes into hospital, they get admitted, you try and get them out as soon as possible. But, they may get a myriad of tests. They might never get to the bottom of what happened. And they don't mobilise for a few days. Then they're waiting 3 weeks for more tests and physios. And then they need rehab, but they can't get a bed. And then they're kind of on this kind of merry-go-round of in and out of hospital, and maybe eventually going to long-term care. And the costs of these is quite high. And there's been a 5,927 increase of over 75s presented to acute hospitals. And you can look for that increase alone. That's not even talking about the people that were already coming. You're looking at 149 million. There's many ICPOP services that can be funded through that. The generalist approach, how does that help between, GP reviews and medications, looking at falls, public health nurse gets involved. We can do ICPOP referral. And we have that shared care planning meeting. And next time they present, they get back home quickly with ICPOP support. And we try and initiate that planning. They may end up in long-term care ultimately, but that's started in the community. There's no need to transition back into hospital for those. So it does make economic sense. It's increased value for the HSE. And we know that the reduction in bed days does save us money in the health system. But there's sometimes these false economies with how we do things. 2 words on the network of care. So there is a big push with the development of the health regions to develop these networks of care, and the network of care for older persons is going to be really important in each region. And there's been direction from the national programme around how these networks of care should be lined up, aligned with the 4M's principles and the 10-step framework for integrated care, because we do want that to be to the foremost so that we can ensure that the services are safe and meet the national international standards for older persons care. And this was me trying to do a slide for this network of care business that we're involved in. But just we've all the jerseys on. Like when I first started doing integrated care talks, we had the Nora with the Galway jersey. From a regional perspective, we have all our counties there. But each of these boxes here should be represented in each local area. And from as an older person's perspective, this is what they should be getting. And I suppose it's our job to try and make that happen. So take homes, integrated care for older people reduces unplanned hospital admissions. We know it improves quality of life, and it does facilitate encompassing what matters to older people in their care. There has been massive improvements in older persons' care, and the ICPOP teams have played a large role, but they're only one part of this overall pathway. And then from the rural health perspective, we know that disparities affect many older people, and the delivery of healthcare to this increasing population is going to need more resourcing and sustained planning as opposed to the reactive planning. And that is my reflection. I suppose a few Bruce references in this presentation, but getting that audience hard, getting people involved in integrated care, sustaining it is even harder. And the idea of consistency of thought, purpose, and action over a long period of time is really important here. And with that, I'll stop and open the floor to questions.
Thanks very much, Michelle. Take a break and a drink. That was quite the presentation. There's an awful lot of information there to download. Does anybody have any questions that they'd like to You can pop your hand up or pop it in the chat. Maybe while folks are thinking, Michelle, if it's okay if I ask a question, I'm reasonably new back to the country, and a lot of the stuff you mentioned there, really compelling, comprehensive geriatric assessment, holistic care, continuity of care, generalism. Like, how is the intersection with general practice and integrated care working? Is there an opportunity? Like, a lot of the things there are kind of the pillars of general practice that we talk to trainees about. Is there an efficiency here that we're missing? Is there something more that we could do?
Yeah, I think there is a big opportunity to do that. I mean, I think if you look at GP training, for example, and similarly geriatric SPR training, we could have a lot more shared training, I suppose, and maybe roles within the ICPOP service for GPs. That would be one aspect, either within training or as salaried roles, perhaps. And I think that's worked very well in other countries. I think, you ask how it working, like, I mean, again, it's the relationships, like, regularly, I'm probably on the phone more to GPs than I would be to hospital colleagues, and that's a good thing. Because oftentimes those quick phone calls can save a whole manner of pain. And I see Rob on the call there, he would probably attest to this. But, so the being available, I think, to GPs, they value that, being able to kind of get in contact quickly. Because we know they're firefighting multiple other things, it's not just older people. So I think maybe appreciation of that, formalizing those a bit better, probably was something we could work on a bit more. But I'd be interested in anyone others' opinion on that. I see a few questions coming in here.
Yeah, there's some questions. I mean, just related to that about the role of the pharmacist,
Yeah,
perhaps,
yeah.
and then something about out of hours clinical governance. So that's relevant for your 5 to 5 call on a Friday. So
I'll go to the pharmacy one first. And 100%, it was a complete oversight that pharmacists weren't funded in these teams from the get-go. And I know there was a piece of work within the national programme around showing the need for pharmacists within the programmes. I don't know if it's actually been published yet, but I know that Emer Hearn was looking into that, because we know the value of pharmacists in the hospital, certainly with our older populations, but and some teams do have pharmacy cover, and it's night and day, I think, to have the pharmacy involved. So I think, particularly with the new pharmacy program here in Galway and that idea of prescribing pharmacists, there's a real opportunity actually to embed those. And I think if I was looking for roles, as well as more HSEP, because I can't get enough physios, OT, social workers, but certainly having a pharmacist embedded in each team would be really, really important.
So the out of
I
hours
just
clinical
wanted,
governance, Michelle, that was another question. Sorry, Robert, we'll get to Kate next and then come
Oh
back to
yeah,
you. Thanks.
thanks.
what was the question there about the governance? Sorry, I'm just looking at it here, wondering about out of hours, clinical governance, and how is consultant leave managed? Yeah. So that has been a challenge, for sure. We've been lucky, I suppose, within our own IHA, that we've had a number of consultants, and from the academic perspective, both myself and Maria Costello still work in the integrated care space, so we provide some cover for leave. Some of the other sites haven't been as lucky, I suppose, in terms of having people on staff. So we make provisions for it, and some of our hospital colleagues kindly cover us as well if we're important. It's difficult though when you've no geriatrician cover even in the hospital, and to be covering the ICPOP service as well. So shout out to the teams that don't have maybe that consultant oversight all the time. The operational leads in the ICPOP teams are phenomenal at keeping the ship steady, and we do try and work together on that. But it is a constant bugbear when they've just provided one consultant to cover a service, and I think that's Mary Claire O'Hara and maybe the diabetes angle as well. It is very difficult to get those covers.
Michelle, Niall asked about integration with palliative
Yeah,
medicine and advanced care planning.
yeah, yeah. We're having actually conversations with this locally, with palliative care. So we have, a lot of, the holistic kind of general approach to patients would be similar to the palliative care teams, and how they approach chronic disease management. I think it hasn't really been teased out. I think it's a pathway that we probably need to do a bit more work on. And I know there's a lot of work going into community palliative care. I've been speaking to Laura Gaffney and I can think of her name now as well, Camilla, around that here in Galway. Because it's the transitions and being able to seamlessly go from palliative without having to present to hospital, if they need be. I think it's the longevity issues are sometimes a challenge in that, someone with dementia, for example, they may not follow a similar trajectory as a cancer patient would in terms of planning and advanced care planning. But I think that's, if you're not talking about it, you're not doing it. So I think even by virtue of us having the talks, the conversations with people around their preferences, in those situations, can be very useful for our other colleagues. But I agree. I think we do need to link well with better, probably with the palliative care services.
Great stuff. Thanks, Michelle. Kate asked around, is there any opportunities for GP fellows to get involved in committee or ICPOP programs?
Yeah, absolutely. We would. I think there's going to be a lot of, like, we have a GP representative on the Network of Care working group, for example, and I think welcome GP fellows that are interested in this area. So for sure, I think we're establishing committees. There'll be lots of work streams and working groups coming off that, and I think it'd be great to have. We've set the net quite wide for this working group because we feel it's so important that all the stakeholders are represented. So yeah, absolutely.
We have one more question in the chat, but before we get to it, I think Robert had his hand up. Did you want to get involved?
I just had a comment, and so I'm one of the consultants who works in ICPOP in the West as well. So I go out in Canavan and stuff, and it's like, since I started in this job about a year ago, I couldn't believe how much progress and development there has been, and largely driven, as Michelle in the background. So I think it's amazing all the work that's been done over time. But I think a lot of the things Michelle said during the presentation, I think, comes down to, the communication. And I think, it's definitely something that I find, I talk to the GPs and communicate with them more than I do, exactly as Michelle said, the hospital consultants a lot of the time. And I think one of the comments in terms of like GP trainees, I think I've been encouraging a lot of the GP SHOs that we've had, I've had on inpatients to consider coming with ICPOP for, like the outer program day, or, the training day that sometimes they have in their third and fourth year. So I think that's, is something that is a good way in kind of to experience ICPOP if you haven't experienced it before while you're in your training.
Great suggestion, Robert, and we can feed that back to the scheme locally. I'm sure it's probably there already. Donald, did you want to ask your question rather than me reading it out? Donald Gill.
Yeah, Donald is a principal social worker in the hospital, and so James guys are particularly those skeptical of support services. Yeah, oh, go on.
Donald. Yeah.
Yeah. Sorry. So I suppose preaching to the choir here anyway now, Michelle. But just that concept of, I suppose, how we do support people, and I suppose that you have to have a condition or you have to have a mobility impairment to get home support. That's not helping our aging population.
Oh my God,
I suppose it is about that social connectivity, someone to meet them for a cup of coffee when they do require that point where they do have the fall, that they have this established relationship with someone to allow them to help them to do the personal care in their house.
And I think it's that early intervention piece, only, if someone is maybe falling a little bit cognitively, but they're fine functionally, they don't qualify for home health, particularly in the West. There was a sharp intake of breath in Dublin when I mentioned the fact that we may get 14 hours of home supports, and they can sometimes get up to 29 or 30. So that whole concept of, and I'm not talking about people who need help getting themselves dressed and washed and everything. It's that social connection, and it's a little bit of prompting. And we know if that gets in there at an early stage, they're much more likely to be at home and independent in the longer term than they are waiting for it to come to crisis point, and social workers in the hospital are dealing with the whole palaver then trying to get them back out. And I fully agree with you.
I think it's almost like we need to fight for, I suppose, the living well concept to be
Absolutely.
integrated into home support.
And I think I was trying to find figures for how much money they put into healthcare and prevention. I didn't quite get it, because as a proportion of the overall budget that we spend in older persons, and I suspect it's too low. But that does need to be addressed as we go forward.
Guys, I might just come in there. Thanks very much, Donald, for your comments. We're committed on this network to finishing at 2:00, guys. We really value your time. Thanks again to Michelle. Thanks so much. It was really comprehensive. I've learned a lot, and it really aligns with the idea behind this network. We'd really welcome your feedback, and particularly we're going to send you a very brief questionnaire. It'll just take a minute of your time, because we're trying to arrange an in-person network event that we have funding for later in the year, probably at the start of summer. We'll send you those options on email, and if you could just take a moment to fill that out, we'd really appreciate it. So for now, we'll see you next month, not next week, for Derek O'Keefe's talk, which will be the 19th of March. Look forward to seeing you then, and thanks again to Michelle, and all the best. Cheers.
Thanks, everyone.